What's up, guys? It's Dr. Price, and I'm here to help you prepare for the USMLE. I'm the CEO and founder of Action Potential Mentoring, and I'm currently in vascular surgery. So let's get this started. Thank you again for joining, and let's learn and let's get better together.
All right, so here's your kidney, and on top of your kidney is a little hat. That is your adrenal gland. All right, and so the adrenal gland has 3 layers. So it's 1, 2, and then 3. And going from the outer to the inner of the adrenal gland, the mnemonic is G, F, R. And that's going from outer clear to the inside. And so these are the 3 separate zones of your adrenal gland. So the first G stands for zona glomerulosa. The F stands for zona fasciculata. And then the R stands for zona reticularis. And these 3 zones or layers of the adrenal gland are important because if you know what's released from there, then you can work with all the pathology that applies to it. So the zona glomerulosa, this is where aldosterone is produced. And so what's the role of aldosterone? Long story short, it's going to increase sodium and then decrease potassium. Okay. And the fasciculata, this is where your corticosteroids are released from. So I'll say cortisol. All right. And there's a ton of roles of cortisol, which we'll get into in a little bit. And then lastly, your reticularis, this is where your sex steroids are created. Okay. And so just now that you have a little bit of background here, so you know the anatomy, you know it's on top of the kidney gland. And what about the blood supply? Well, blood supply comes off of, here's your renal and here's your aorta. So it's going to be a combination of both. So you're going to have blood supply to your adrenal gland off of your renal artery as well as off of your aorta. All right. And so that's kind of like the main gist so far for anatomy. If we're talking about Addison's versus Cushing's disease, this is the big dilemma. So let's start off with Addison's. So another name for Addison's is essentially chronic adrenal insufficiency. So it's chronic adrenal insufficiency. All right, and so knowing what's made in the adrenal glands is going to help you figure out the symptoms for Addison's, because if none of it is working because it's insufficient, then you're going to get the symptomology that you're looking for here. Okay, so the 2 main things that you lose with adrenal insufficiency is going to be the glomerulosa and the fasciculata. All right, so we're going to put X's in these 2 areas, the glomerulosa and the fasciculata. All right, and so there's a bunch of different ways that you can get adrenal insufficiency, right? So there's going to be an acute and a chronic version. All right, so let's just like take an overarching term here. We'll take adrenal function. So here's your adrenals. It can be either underactive or it can be overactive. All right, so we're going to be going down the underactive side of the tree here. And so underactive, it can be either something that occurs acutely or something that occurs chronically. All right, and then this is where Addison's falls under, is under chronic adrenal insufficiency. All right, and so how can you get that? Well, number 1, you can either get it from adrenal atrophy. So one of the main ways is adrenal atrophy. And you can get atrophy of your adrenals from overabuse of steroids. So then your adrenals feel like they don't have to do anything. Or you could also have autoimmune destruction. So I kind of think of adrenal atrophy, I break it up into 2 characteristics. So it's either going to be somebody that's basically in like the USA or somebody that's in a foreign country. All right, so we'll just say developing countries. And we're just going to play most common odds here. All right, because a lot of boards is basically reading in between the lines and knowing what is the best bang for your buck on this type of a question. So if somebody has adrenal atrophy in the USA, you're thinking it's specifically going to be Addison's from autoimmune destruction of the gland itself. So basically you have autoantibodies that come in here and they attack your adrenal gland. All right, but if you have adrenal atrophy in developing countries, the best bang for your buck guess on these questions is actually going to be tuberculosis destroying your adrenals. So TB, destruction of adrenals. All right, and so both of these are common test questions. So if it's somebody in a developed country, and most often they'll say like the USA or one of the more developed countries, usually it's going to be autoimmune destruction. If it's somebody that is in, let's just say Africa, for example, they'll pick like somewhere in a big continent that has less technology and more infections, etc., and they'll just be stereotypical about it. I mean, it's just the boards, that's how it is sometimes. And so with that, you can assume that it's tuberculosis that caused the adrenals to get destroyed. So what do you do to treat Addison's disease, or if somebody comes in and they have adrenal crisis? All right, so let's talk treatment here. All right, so what's the big issues? If somebody has Addison's disease, well, if you remember, if you scroll up here, we said that they don't have aldosterone at all. Okay, so if they don't have aldosterone, what do you think their blood pressure is? Well, if they're not able to retain sodium, that means they can't retain water. So they're going to be dehydrated and have a low blood pressure. Okay, so the treatment, the first thing is you want to look at their blood pressure. Okay, so you want to give them IV fluids, all right, because they're going to be hypotensive. All right, and so once you give them the IV fluids, you give them glucose with it. All right, so why do you give them glucose? All right, so if you remember, these patients are going to be deficient in their corticosteroids. All right, so if somebody's deficient in their glucocorticoids, then they're not going to have the glucocorticoid-induced production of glucose. Because remember, glucocorticoids cause gluconeogenesis. It's in the name. Glucocorticoid causes gluconeogenesis. So they're going to get glucose in their fluids because of hypoglycemia. So therefore, you just kind of inferred that somebody with Addison's disease is going to be hypotensive and hypoglycemic. Okay? And next thing you could do is, if this is really acute Addison's, so we said it's like that Waterhouse-Friderichsen from your Neisseria infection. So it's an acute adrenal crisis. So you can actually give them something to cause vasopression. All right, so you want to give them something that is a vasopressor if it's acute shock. All right, so what are some vasopressors that you know? Well, first thing I think of is like epinephrine, norepinephrine, phenylephrine, and actually vasopressin itself. So let's just talk about how some of these work. And obviously you don't give all these at once. You give maybe one, try it, see if it works. If that doesn't work, try another one. And there's some pretty complex titration strategies, which you don't need to know for step 1 or step 2 for that matter. That's more like once you get to clinical level. But you have to know how these drugs work, however. So epinephrine, what that does is it's going to bind to alpha 1, alpha 2, beta 1, and beta 2. So epinephrine binds to all of your sympathetic autonomic receptors. All right, so alpha 1, alpha 2, beta 1, beta 2. So I think E for epinephrine and E for it binds to every one of them. All right, so E for epinephrine and then E for binds to every sympathetic nervous system receptor. Okay, and then the next is norepinephrine. Norepinephrine, I think NE stands for not every receptor. Okay, so NE stands for not every receptor. So it's going to bind alpha 1, alpha 2, beta 1, but not beta 2. Okay, so norepinephrine binds to the same exact crap as epinephrine except for the beta 2. So NE stands for not every receptor, and the one that it's lacking is going to be beta 2. So not every sympathetic receptor. All right, next we have phenylephrine. Phenylephrine is going to be great for binding to alpha 1. Remember, alpha 1's entire role in life is to cause vasoconstriction. All right, that's like the major number one thing you have to know about alpha 1 is it causes vasoconstriction. So how I write vasoconstriction is like this. Vasoconstriction with the 1 as my I. All right, so alpha 1 causes vasoconstriction. All right, and then vasopressin. So where have you heard of vasopressin before? Well, vasopressin is also called antidiuretic hormone. So I'm just going to put here vasopressin, aka ADH. It's the same exact thing. Causes antidiuretic hormone as well as vasopressive activity. All right, and so vasopressin binds to two receptors. So it binds to V1 and it binds to V2. All right, so V for vasopressin, V for the receptor it binds to. And so my mnemonic for the V1 is actually the same one as it is for alpha 1, is it's vasoconstriction. All right, so the 1 for V1 should remind you that it causes vasoconstriction just like alpha 1 does. And then the V2, the 2 actually stands for H2O retention. So it causes water retention. So V2 causes H2O retention. And you have to know what each specific receptor causes. So if it binds to V1, it causes vasoconstriction. If it binds to V2, it causes water retention. Well, guess what? Remember we said patients with Addison's disease, they need IV fluids because they're hypotensive. And they also need a vasopressor. So to me, vasopressin seems like a pretty good bet because it's causing vasoconstriction to ramp up your blood pressure. It's also causing water retention, which they need because they're also hypotensive and fluid depleted. So you can use any of these medications and you just gotta kind of use your clinical judgment of which one to use first. Questions on boards will not ask you which one to use first, but they'll ask you for picking one of the answer choices that actually does cause vasoconstriction. Okay, so those are some of the main ones that I think of whenever I think of vasoconstricting medications. Okay, and then next thing you got to do in these patients' treatment, so if somebody comes in with Addison's disease, is you want to give them electrolytes, right? So you want to do electrolyte management. All right, and so remember, what was their electrolytes if they had Addison's? So we're going to say adrenal insufficiency, it's going to cause, first things first is it's going to cause low sodium. So you replace it. It's going to cause high potassium, so you get rid of it. It's going to cause a low amount of pH. So why is your pH low? Well, it's because you retained all of your hydrogen ions. Remember, so you got a non-anion gap metabolic acidosis. All right, so you basically fix these electrolytes. The big problem here is the potassium. So hyperkalemia is a huge, huge issue with these patients. And so why is that? Because hyperkalemia can cause your heart to cause all kind of funky rhythms. And so what do you do if somebody has hyperkalemia? Well, that's like a whole lecture in and of itself. It's actually something that I'll probably address at one of these crash courses because it's so important to know. But if you have a high potassium level, you want to drop it really quickly because of the cardiotoxic activity. Okay, and so first things first is for the treatment for hyperkalemia, you want to give them calcium gluconate. All right, so calcium gluconate is super important. It doesn't actually lower your potassium. Let me repeat that. Calcium gluconate is the first thing you give, but it doesn't actually lower your potassium. And so why is that? So if here's your action potential of your heart. So let's just draw an action potential. All right. So shout out to Action Potential, my company. So you have your action potential. Here's going to be your threshold. Okay. And so what happens is if somebody has hyperkalemia, it's going to raise their resting membrane potential up higher. Okay, so the pink line here is going to be like your resting membrane potential. Okay, and so patients with hyperkalemia have an elevated resting membrane potential. So that means that they're more likely to fire off the signals of the heart because they're closer to the threshold. Okay, so what you do is you give calcium gluconate because calcium gluconate is going to cause an elevation of the threshold. All right, so calcium gluconate elevates the threshold. So potassium is going to raise, so we say high potassium raises the resting membrane potential, whereas giving the calcium is going to increase the threshold. So if you increase the threshold, you're less likely to break it and fire off excessive amounts of action potentials. Okay, so basically it just stabilizes the cardiac membrane. All right, so if you get nothing out of that besides this one phrase, I want you to know this. Calcium gluconate is going to stabilize cardiac membrane. All right, and so this is really, really important to know. You will get this on test questions, you will get this on rotations, you will get this on PIMP questions, you will get this when you're actually taking care of people. Somebody has hyperkalemia, it's not okay, you got to fix it. First thing you do is give them calcium gluconate. All right, so calcium gluconate is step number one. You give that to stabilize the cardiac membrane because it increases the threshold so you don't fire as many action potentials. Okay, number two, what else can you give for hyperkalemia? Well, first thing I would think of would be insulin, because insulin shuttles the potassium into the cell. Okay, so you give them insulin plus glucose because you don't want to cause hypoglycemia from all the insulin use. All right, so insulin plus glucose is the next thing. All right, the next thing I'm thinking is I would give somebody sodium bicarb. Okay, so sodium bicarb is another safe bet. And so you can give the sodium bicarb because basically if you increase the pH here, it's going to decrease the amount of hydrogen ions that are in the extracellular fluid. And that's going to compete with the amount of potassium for intake into the cells. So basically, if here's your cell, all right, so sodium bicarb is going to basically cause there to be a low level of hydrogen outside the cell. So that means there's going to be more relatively inside the cell. Okay, because bicarb is like a base, right? So you're making it more basic so that there's therefore like a less concentration of acid outside. Okay, so now there's all this hydrogen inside the cell. So if there's a bunch of single positive charges inside the cell, the potassium is going to be fighting for its uptake with the hydrogen. Okay, so you can give the sodium bicarb. That is like rarely used as much, but that's something else that you can give. So it basically just, it outcompetes the potassium for the cellular transporters. Okay, next, I would give them actually a beta-2 agonist. All right, so what's the most famous beta-2 agonist? And the answer would probably be albuterol. So if you've ever had asthma or you have a family member that's had asthma, what do? They give them an albuterol inhaler. All right, so it's a bronchodilator. The thing is beta-2 agonism is actually going to stimulate, it's going to stimulate your sodium potassium pump. All right, so that's going to cause you to have a lower level of potassium. All right, because remember, the sodium potassium pump, its whole role is to pump K in. So the mnemonic is like pumpkin. Pump K in. All right, so it stores all of that potassium inside your cells so it's not floating around in your blood with hyperkalemia. All right, and then so next, I would say you can give a diuretic. So the most common is to give a loop diuretic. And so the classic drug for that is going to be furosemide. So furosemide causes you to pee out a ton of potassium, right? So the hyperkalemia can be treated by the loop diuretic because you pee out your potassium. Okay, and if all else fails, if you're at my very first board review, then you remember the indications for dialysis are AEIOU. The E stood for refractory electrolyte levels. So you can do dialysis for potassium that you cannot lower no matter what you've tried. Okay, so those are really the first major things I want you thinking of. And if it's a long-term high potassium, actually, let's just move dialysis down to number 7. And let me throw in something that you can kind of use as a last resort for chronic hyperkalemia is actually K-exolate. All right, so the mnemonic for this is K exits later. So K-exolate, K exits late. Okay, and so if you have this K-exolate, what happens is it causes you to poop out potassium slowly over time. Okay, so K-exolate causes K to exit late. So you poop out potassium. And obviously that's not something that can happen immediately. You don't just take this and start crapping out gobs of potassium right away, but like over time, you start pooping out all the potassium. Okay, so those are really your treatments for the hyperkalemia. And so remember, patients with Addison's have high potassium, so you got to manage that. All right, and then lastly, we talked about these patients are going to have low levels of their glucocorticoids, right? So we said you give glucose because the glucocorticoids, those cause gluconeogenesis. So if you don't have them, then you have hypoglycemia. All right, so you can just replace glucocorticoids. So that's going to be my next thing for treating Addison's is replace glucocorticoids, as well as your mineralocorticoids if you can. All right, so by replacing your glucocorticoids, that's just given like high dose hydrocortisone IV. All right, so I'm just going to say high dose IV hydrocortisone. And that's usually the mainstay of treatment for these patients with Addison's. All right, and then for the mineralocorticoids, you can give them high dose fludrocortisone. So fludrocortisone is the drug you need to know, which is a synthetic mineralocorticoid. All right, so fludrocortisone is your mineralocorticoid. Hydrocortisone is what you usually use to replace the glucocorticoids. Okay. Last thing I want to mention about Addison's, and this is for like a bonus point that a lot of people don't really know, but it's kind of an interesting fun fact that you'll see occasionally makes its way onto test questions. So say you get labs on somebody with Addison's. We talked about the sodium levels, the potassium levels, the hydrogen levels. One thing I want to mention here is you're going to have something called eosinophilia. All right, so this is really interesting to me at least. So you have eosinophilia. And why is that? It's because usually corticosteroids come in here and they actually suppress your eosinophil production. All right, but guess what? These patients, they don't have corticosteroids. So guess what? You get eosinophilia because there's nothing to basically put the brakes on them and they just keep producing and producing. Okay, so kind of my thought processes on this is corticosteroids are almost like the seatbelt for eosinophil production. So the corticosteroids are deficient, so your eosinophils, they just put the pedal to the metal and they just make a ton of themselves. So that's really, really cool that you'll see with Addison's disease and not very many other things. It's very, very rare to see eosinophilia. But Addison's disease is one of the causes because you have no steroids to cause suppression of your eosinophils.
Thank you guys so much for joining today. If you found that was helpful, find me on Instagram at Action Potential Mentoring and shoot me a DM saying what your favorite part of today's lesson was. If you have any questions or you'd like some personalized one-on-one assistance with preparing for the USMLE, learning what it takes to become a stellar applicant and matching it to your dream specialty, DM me the words VIP Mastermind. Again, that's VIP Mastermind. Talk to you soon.